Welcome to our webinar today. This is Steve Anderson. Our topic today is coding for 2017, new codes and what you need to know to file correctly. Our topic expert today is Maribeth Brown from the Total Patient Service Institute. Maribeth is one of our lead practice advisors. She's been with Total Patient Service for well over a dozen years and has been in dentistry her entire life. Maribeth started in her first dental job at age 9 years old in her father's dental practice and has been at it ever since. So she has years and years of wisdom and accumulated expertise that she is going to share with you, along with the latest changes in coding that will help you code successfully to get reimbursed and maximize your reimbursement. So a couple of notes. This is packed with information. Today, a lot of detailed information, and we're going to move relatively fast in the interest of time. We will post the notes from today's webinar at crowncouncil.org later today. Under the training tab under webinars, there will be a link to this webinar today so that you can re-watch or share with team members that were not here, as well as download a PDF file of all the detailed information. So with that, I'll turn it over to Maribeth. Maribeth, thanks for being our topic expert today.
Well, thank you, Steve, and thanks for inviting me to be a part of the team and a member of the Crown Council. What a great group of eagles to fly with. Thank you all for joining us for 2017's current dental technology and terminology changes. As every calendar year for the past dozen years has presented itself, the CDTs have changed, and so that we can help you clearly communicate with your patients about proposed dental procedures, accurately document dental procedures, services performed, and appropriately bill your patients for services, we wanted to give you the overview of the 11 changes for this year. So Steve, if you'd like to move to the next slide for us. Thank you. And we just talked about that. The last reason that we do this, and maybe a primary for some, is the third-party payers that we report our dental procedures to. So we're ready to get into the slides. So this year, they've added a new code, the D0414, laboratory processing of microbial specimens, to our repertoire for billing and using. Many people have been using the D415, the D417, and the D418 in the past. And so they each hold a different purpose in the whole process of collecting and properly diagnosing and transmitting information to the labs and then back to the patients. So now you have 4 great codes that we can use for this specific area in dentistry. All right, we're ready.
To clarify this, so this would be if anybody is using microident from Hind Diagnostics or any of the oral DNA products, this is the code that's used for those, correct?
Yes, it's going to be one of the 4, Steve. So we actually will use all 4 of those codes now.
Very good.
So yeah, this one is actually the code that we would use in processing the information to Hind or oral DNA, as you said, or any of the other labs that are doing sensitivity for diagnostic purposes. So we would encourage using all 4. A year or so ago, there was new information in gathering a dental disease for our patients, and they called it Transillumination technology. The company, Dexis, has the biggest one on the market right now, the Caries, and because it's a great diagnostic code, the CDT has given us an actual code that we can use it in billing for, and that's going to be the 0600. So it is, if you're using a Caries view, it's the illumination process in diagnosing dental caries disease. And someone may ask, we have a Diagnodent, can we use this code for utilizing the Diagnodent? And the answer right now is no, because their technology is different. So this only will be used in illumination technology. Let's go to the next slide. Now, many people work in the pediatric area and general dentistry and in pediatric specialty, and past with code which was D1501, which was a space maintainer, and gosh, it's been around for probably as long as I am. The new code that has come up with is a D1575, and it's called a distal space maintainer. Often in the development where we've lost that first molar and we need to keep and retain space for it to come in play, the primary is gone and we're waiting for the permanent to come in place, it's been subgingival, and so the other code was not deemed appropriate to use in that situation. So for those that place space maintainers, this D1575 will be new to add to your repertoire. And then we can move to the next slide. All right, so here's one of the biggest ones that's a change for us. And for many, many, many years, we've tried to figure out how to address gingival inflammation. And in the past, we've been very creative using some codes, the 4355 or the 1110, the health prophy, to help patients with the gingival inflammation. And the CDC and the ADA and Academy of Periodontology have all come together and given us a great new code, and it is going to be the D4346. So when you have a patient that presents with gingival inflammation, but no bone loss, and they're more than a super prophy, is what we used to call them, we will now have an excellent code to report what we've done and also alert the patients that they're no longer in a good state of health. So we were really excited about that one. The second code that is great, and this works along with our replanting and scaling codes, is implants have become such a big part in dentistry now that when there is inflammation or root planning and scaling that needs to be done in the presence of an implant, reporting the code 4341 or 4342 was inaccurate because, of course, an implant is not a root of a tooth. So because of the wording, the CDT came up with a new code so that we could actually take care of any infection or inflammation around a singular implant. And that code's going to be a 6081 now. So remember, if you've been in the habit of using that 4355 or the D1110 in the presence of inflammation, you see the big round circle to the left of the screen. Let's stop using that and start using the 4346. All right, let's move to the next code. Fantastic.
Maribeth, we're losing your audio every now and again, and I think you're on the speaker on your computer. And if you are, if you'd just either put on a headset or slow your speech down a little bit, I think we'll be okay.
Great, great, thank you for that. So the next, with implants, as we said on the rise, there's often when we place an immediate implant and we need healing to take place before we want to present the patient with a final restoration. So the D6085 Provisional Implant Crown has been a wonderful code to be able to allow the healing to take care, the gum tissue to settle in, and then the final restoration to be placed. So in the past, we haven't had a code to deal with that. We've had a healing cap that we could use, but the code has been changed for us, so now there is a 6085 for provisional implant. So for immediate loads, this is a great code to use. All right, thank you, Steve. All right, the next code that we have that's come to us is a 9311, and it's a consultation with medical health care professionals. And we firmly believe that the oral systemic link is the transition between medicine and dentistry is alive and well, and there's oftentimes that the patient's health is compromised in ways that the physician and the dentist need to consult. And so now as the providers speak with one another and plan their procedures, we have a documentation code of a 9311 that we can utilize so that the dentist and the other medical care providers can discuss the patient's treatment and coordinate care. Very good. Now the next several codes, 99.1, dental case management, and the next 4 codes are all going to be codes to help us document what we're doing with either children and or our seniors that come to our office that need some additional help in either maintaining their schedule, so this 9991, dental case management, addressing appointments and barriers, is really helping solve transportation problems. So it's either going to be your very young children or your very old seniors that can no longer drive themselves to the appointments, and we need to assist with facilitating rides and healthcare transportation. And again, this is a documentation code so that we can adequately code the time that we're investing in helping our patients stay scheduled. And then moving forward, the next code is 9992. And again, this ties to the same thing. It is a case management care coordination code, and it allows you to work with other healthcare providers to maintain optimum results for your patients. So it could be, again, a senior that has nurses on staff that are assisting take care of them because they no longer can take care of themselves, and this is a way for you to transfer the information to them so that they can then be the care provider that the patient no longer can do. Or it could be the opposite end of the spectrum, and it could be a young child that is in need of assistance and coordination. And the next code is the 9993, and it goes along with motivation and talking with the patients about possible behavioral changes to modify negative oral health behaviors. It could be that child that only brushes their teeth once every 6 months when they're coming in. It could be a senior that is just no longer has the dexterity to brush on their own, and so we need to work with making sure that we can find ways to help them with their health care. And so all of those conversations can now be documented utilizing the correct coding. So you've got the 9991, 9992, and 9993, and then the final code in that same area is 9994. And then Steve, if you can move us to the next slide. Perfect. So we've got an overview, and this is very full slide. Really what the rationale is for adding these 4 codes was because medical care is becoming multiple layered for both our young and our old. Often having a trail of who you've spoken to, what you've spoken about, and your directives has been hard to keep up with in the dental note. And so with these 4 codes, being able to be a good case manager or concierge of care, being the quarterback of the systemic link of the oral health, this gives us 4 great codes to be able to use as we communicate with the different providers of sustaining health, whether it be a parent, whether it be a nurse, whether it be a doctor or physician, or whether it be the child itself. So that pretty much rounds up our brand new codes for 2017. I said there's 40 additions and changes to some terminology that we're not going to currently cover. So what we wanted to do is cover those first 11 for you so you could be a bridge to what the changes were. And then we wanted to go back for the last year or two and make sure that we address coding changes that had happened in the last 24 months so that we could all adequately use our coding for communication purposes. And what we found is there are 3 very underutilized examination codes. As the TALPS team goes around from offices, we always look at procedure code analysis to see application and trending, and what we've noticed is that these 3 codes that have come in the last 24 months have been very underutilized. So the 0170 is a reevaluation problem-focused code. established patient, non-postoperative visit, and then the D0171 reevaluation of a postoperative visit. So they're both very different, but very important to be able to use. And then, of course, the D0180, comprehensive periodontal evaluation for a new or established patient. And Steve, I'm going to ask you to advance for one slide for me.
Okay. You say it one slide ahead.
Yeah, just go one forward. So the D0180, this is just a great breakdown of when to use it. This procedure indicates a patient showing signs and symptoms of periodontal disease, or for a patient or with a risk factor such as smoking or diabetes. So new patient presents and they have either periodontal symptoms or they're smokers and or have risk factors. Instead of utilizing that 0150 that we've all gotten so comfortable with, this would be the appropriate code to use. On a second side, if a patient is of record and they've had a life change or a health risk factor change or a periodontal change, then instead of utilizing the 0120 code as we would for a periodic evaluation, we would apply the 0180 because there's been a change in health. The patient showing signs and symptoms of periodontal disease, or they have had a change in health factors. So I hope that that helps understand a better way to use the 0180 code as well as the 0170 and 0171. And then let's advance to the next slide. The Palliative Emergency Code, Dr. Blair introduced us to this 5 years ago, the 9110, and it is when patients come in with a localized problem. It's not for an appointment that was registered, it wasn't for something that we treatment planned, but it's in between their periodic visits and they have got a problem. Or it's your episodic patient that comes in once every 4 or 5 years that has an emergency treatment problem. So this typically is a time for you to utilize an exam code as well as a palliative emergency treatment code. If you're going to be writing just a prescription, if you're going to be providing dental services for the patient at this time, then we would not apply the 9110 code. But if it is just an evaluation and a prescription, then what we found is that this code has been very underutilized for many, many patients that come into practices. And there's another code that we would like to go back, if I can get you to go back for just a second. So it's the 9930 code, and it is treatment for complications post-surgical. It's unusual circumstances, for example, a dry socket following extractions, or let's say someone's had multiple teeth removed and they've got some little bony pieces that are coming out, then this 9930 would be a phenomenal post-operative code to use, and we don't see it posted very often either. Thank you, Steve. We can move on to the next. In the past, 2 years ago, we learned about a new code. It was the 9931 code. And I need to let you know it's been deactivated. So it's no longer an active code. So let's make sure that we put it in our inactive code pile. Instead, what the CDT has done is they have added 4 codes. So the 9932 is for cleaning inspection. And you'll notice the one is an upper denture, one is a lower denture, one is an upper partial, one is a lower partial. So the 9932, 33, 34, and 35 are all cleaning and inspection of removable appliances, whether they be full or partial, upper or lower. So at the time that we're doing a hygiene appointment or periodontal maintenance appointment, if we are cleaning an appliance, then we would apply this code as well. So that was a code change I thought we should know about as well. And we can go on to the next slide. Thank you. So the topical application of fluoride varnish, the 1206, is such a fabulous application for so many of our patients to help them. And what we found is that a year ago when the risk assessments came out Remember, they were the D0620, which was moderate, or 0603, which was severe or high. If the patients are in either one of those categories, then the 1206 is a wonderful adjunctive code to offer them, as well as anybody with, of course, just good interest in keeping their teeth. But for purposes of applying for benefits for a patient, the third party, in comment box 35, if your patient is a moderate or severe risk assessment, please make sure to put that in there. It just allows them to have sometimes access to additional benefits. Okay, and on to the next codes. We have the 1354, which is the interim caries arresting medicaments. And if you guys remember, this code is worked so well for patients that have a high caries risk, and they need to be able to sleep with fluoridation trays that apply the fluoride, maybe with also the calcification or recalcification. They have a lot of incipient decay. So we found that this 1354 is a phenomenal opportunity for patients that have thin enamel, high caries rate, maybe bulimia. They could possibly be going under radiation or chemotherapy. They might have dry mouth syndrome. So lots of different health care situations that would cause them to have higher dental caries disease. And this 1354 is a phenomenal way of helping them with those additional fluoride treatments that we do in office. And we can move on to the next slide. All right, so everybody knows that sealants are not a lifetime service that we provide, and that there are often times that the children or adults will eat ice or chew hard types of foods that will crack or have them fall off. And so the sometimes it could be the process that we're doing in the office, that the contamination and they're not staying on the way we would like. A rarity, but something that we need to always watch as well. If within the first year that we've placed a fluoride, a sealant, often we would like to replace that at no charge, but we really want to be able to track what we've done. So the 1353 is a great way to track how often you're having to replace a sealant that's within 12 months period of time. So again, it's a great code just to be able to watch on our side internally how many sealants are needing to have touch-up or repair done. And we can go ahead and move on to the next slide. All right, there's some really great crown and bridge codes that are being underutilized. I know that third-party payers can be just really sticklers about paying for the 2950, that foundation or build-up under a crown, and their criteria is 60% or more of the tooth needs to be missing in order for them to consider coverage. So several years ago, probably 24 months now, the 2949 was introduced to us as it's a restorative foundation, and it is the sister code to the 2950. So if you're being rejected on your buildups, you might ask the insurance companies to consider covering the 2949 for your patient. So it's a great additional code to use, or it might be the code that you start utilizing on the instead of the 2950, depending upon the amount of tooth structure that's missing. There's two other codes. These are both in preparing the tooth so that it has adequate crown for the crown to sit on. And there are times that a gingivectomy needs to be performed so that you have access to the tooth. So that's that 4212. The other code is crown lengthening, and of course that's where we're removing some of the bone to expose tooth so that the crown can have enough structure to sit on. So the 4249. So those are 3 additional codes for crown and bridge for when the situation calls for it that are very helpful in billing and recording what you're doing in the offices. And we can proceed to the next code. Thank you. So 2799 provisional crown. You know, earlier we talked about a provisional crown for an implant. Well, there's also the 2799, which is a provisional crown for a natural tooth that, you know, maybe it's got endo and we're not sure that this tooth is long for the world, waiting to see if it's going to heal properly. Maybe the tooth has got cracked tooth syndrome, and so you want to prepare it and temporize it so that you can see if the patient's going, if the symptoms are going to dismiss, so that you can seat your permanent crown or impress for your permanent crown. And so the 2799 provisional crown is a wonderful code to use, and you'll notice that the code that's been removed was the 2970, the temporary crown for a fractured tooth. So we have replaced it about 12 months ago with the 2799 and wanted to make sure that you were on track and on top of using that correct code. So instead of using the 6085, that provisional implant code, remember to use your 2799. Thank you, Steve. All right, some endodontic codes. Many of our practices use endodontic services for their patients or bring specialists in. And what we found is that there are often defects because of the infection at the root tip of the tooth. And about 24 months ago, the CDT changes were when there were bony defects or bone defects at the apex of the tooth. We couldn't use periodontal coding to correct that, so they created the endodontic codes for us to use. And there's the 3427, which is surgery without an apicoectomy at the apex of the tooth. There's the 3428, which is that bone grafting in conjunction with root tip surgery for a single tooth site. And then there's the 3429 bone grafting when you're any additional tooth, when you're doing any apical restructuring of the bone. Of course, there's also the 3431, which is biological materials for soft tissue integration, and then the 3432 guided tissue regeneration per site. And all, again, these are not for periodontal treatment, but these are all for endodontic codes or endodontic treatment. So for our endodontic specialists and our general offices that are offering endodontic services, here are 5 very underused codes that often you address in your practice. So we look forward to you using them in the future. As we move forward, we've got some information on overdentures. Every once in a while, I'll even see this on the Crown Council website, which is what do we use, what codes do we use? So the 5867 is replacement of parts or semi-precision attachments for the male or female components of an overdenture. And with our baby boomers moving forward, we're getting more implants and more overdentures. So it's really nice to make sure that we utilize and have those codes handy. Also, you've got the maintenance and cleaning of your prosthetics. So that 5993 is a phenomenal code for your patients that have your overdenture, that you know, they've come in for their cleaning, whether it's a perio maintenance or a healthy mouth cleaning, and we're taking care of their oral tissues. Well, now we have to make sure that we clean and maintain their fixed or overdenture prosthesis. So those are a couple codes in the overdenture area. We talked about bone grafting with endodontics, so now let's talk about bone grafting in our periodontic area or with our implant area. So the 6103 is a great code for utilizing defects, bony defects. It doesn't include a flap or entry, but you see a bony defect and you want to address it, then add some bone to that area. This would be the code to use in that area. If you're doing implants, at the time of implant placement, you're needing or wanting to add bone for support and structure, then the 6104 code would be the proper code to use there. And then the 7953 bone replacement graft for ridge preservation. So you've taken the tooth out, you're not placing the implant that day, but you have intention of placing it in the future, then we would want to use the 7953. So we have the 6103, the 6104, and the 7953 are all great bone grafting codes for us to be able to use. And we can move forward. Orthodontic retainers are another area of our offices. You know, patients come in and they've lost their retainer or they broke their retainer. So we've got the 8692 code that we can use for replacement or lost or broken retainers. Those might be the Hollies or the Viva retainers, or they might be the cemented or the bonded retainers, which would be the 8693. So if we have to re-cement or rebond a fixed retainer, we want to use the 8693. And if we're going to replace one that they either lost, throw away, or the dog ate, we want to use the 8692. And then we can move forward to the next codes. All right. So people have sensitive teeth for all sorts of reasons. And so there's two great codes to use for applying desensitizers to teeth. So you can use your fluoride for full mouth fluoridation, of course, and protection. But if they've got a place that's really uncomfortable and it's specific, then you want to use the 9910 desensitizing medication for root sensitivity. The other code is going to be a 9911, and it's a desensitizing resin for cervical and or root surface sensitivity for patients. So they may come in for their hygiene appointment and have specific areas in their mouth that are extremely sensitive. Then either one of these codes, the 9910 or the 9911, would be appropriate depending upon the product that you have. If it is if you're utilizing the resin fluoride, then please or desensitizing medication or fluoride treatment, then you do want to make sure to use your 9911. And then the last but not least codes that we really wanted to talk about are our cancellations and missed appointment codes. You know, the more often we can document our patients' activity in our practice, the better we can help them and moving forward. And so a year ago, the management codes were suggested for the 9986, which is a missed appointment code, and the 9987 for a canceled appointment. All of us in the practices for years have kind of made up our own codes to use so that we could keep track of our patients, and many of you might be continuing to use your own codes, but know that if you're using any Medicaid supplements or Medicare supplements, then these two specific codes would be very important for documentation of patient activity within your practice versus your own personal codes. So we're recommending to our patients, practices moving forward, to utilize those standardized codes so that we can all communicate to our patients effectively on their ledgers and with their statements their activity within their practice. And a couple helpful comments on keywords when filing for replanting and scaling. You know, of course, it's so important to make sure that we have that 6-point measurement for all the teeth that are present in the mouth, and that we have the level of recession marked, and the bleeding upon probing. Whenever there's a bleeding spot, we need to make sure that that's recorded as well. And if they have any pus or exodus that is present, we need to make sure that that's adequately marked as well, and then the mobility. So those are the non-debatable must-haves on every measurement chart that we have in the practices. So when we're filing for root planing and scaling, it's important that we make a comment on the bleeding upon probing and indicate where that activity is and where the health of the tissue is present. We need to make sure that we've got our pockets that are 4 or 5 millimeters or greater with attachment loss. And if we don't have that recession adequately marked, of course, we can't tell the true loss of the true bone loss that's present. And of course, making sure that you've got your radiographs that support, so your bite wings and your full series of x-rays, or that great panoramic digital panel that you might have as well. So it's important that you have your radiographs, your measurements, and your charting all done, and that you make note within box 35 of the areas that you've seen that put this patient into the need of root planing and scaling. So chronic and generalized severe periodontitis with bleeding upon probing, and then of course your presentation of findings will be very important in box number 35 when you're filing for your root planing and scaling for your patients. And then the last but not least is going to be our build-up code. So we can move to the next slide, Steve. There we go. And there's a lot of information on here. Again, we'll be giving this to you in the PDF form. But really what it says is that the key indicators for a buildup are, as we said, more than 50%, 60% of the tooth missing for the insurance companies to consider a buildup. So if you have intraoral photos as well as to document the loss of tooth structure. After you've taken the restoration out of the tooth, if you take another intraoral photo to demonstrate the actual loss of tooth structure. If you talk to the patient has talked to you, or you have documentation that the patient's had cracked tooth syndrome, letting the insurance company know that the primary purpose for this buildup in crown is to help the patient with a cracked tooth syndrome. Or if the patient has come in and out of the office several different times with sensitivity to percussion or sensitivity upon chewing, and you suspect that there is a crack or a fracture within that tooth, that you've done bite adjustments, any of those pre-diagnosis or pre-treatment notes to send on to your patient's third-party carrier would be very helpful for receiving benefits for not only the crown, but also for the build-up that, if you so placed one in the tooth, are really great pieces of information so that you can adequately help your patients receive the benefits that they've have applied for during the year and would like to use towards their better health for the ongoing of their perfect maintenance of their teeth. So Steve, that just about wraps up all of the coding that we've done for the 2017 year. And I'd really like to thank our sources, the information. We've gotten the ADA as for one of our key components of coding changes, as well as Practice Boosters and Dr. Charles Blair. So those are always our resources for gathering our information to be able to pass forward to our great Crown Council listeners.
Good deal. Thanks, Maribeth. A couple of questions that have been submitted. Here's the first one. It's my understanding that the 9991 through 9994 codes are truly for documentation only and therefore will not give any reimbursement. Is that correct?
At this point, that is absolutely correct. They are documentation only codes, just so that we can keep track of who we've spoke to and how we've directed that patient's care. So that is a true statement.
Next question is, how do all those codes differ from the 1330 oral hygiene instruction? So this is referring back to the the 1330 code. So how does it differ from the oral hygiene instruction code?
You know, the oral hygiene instruction code was a blanket code that went over maintenance and helping patients one-on-one. So when you think about the coding itself, the 9994 would probably be the best code to coordinate with that oral hygiene instruction in the past. But when we talk about the 93, the 92, and the 91, it's really working with another third party. So it's really speaking to the care provider or speaking to the medical the physician versus the patient itself. So I would think that if we looked into the wording specifically, the oral hygiene instructions is from me to you, Steve, versus from me to maybe your care provider.
Got it. Next question is comments. We quit using the 0180 code because insurance was denying it. Have been your experience or not?
Hasn't been my experience as we've presented it, you know, for the last 2 years. And if they've denied the code, my only comment would be in box 35, did you attach the 0180 with a change of health? And did you support, you know, their periodontal measurements chart go along with it? Did you actually, you know, request them to reconsider? And if they denied it, did they then go ahead and ask for it to be reimbursed under the 150 code?
Got it. Next question, just a request for a quick review of the 4346.
All right,
just repeat
let's
that.
look at that. All right, so the 43,
over to that.
Yeah, I was going to say the 4346 is our scaling in the presence of generalized, moderate, or severe gingival inflammation. So let's say a patient has a 4-millimeter pseudopocket and they've got multiple bleeding spots in their mouth. So what we would know is that with the presence of the bleeding, they're not a healthy mouth, because healthy mouths don't bleed, right? So the 4346 is a tissue inflammation issue and not a healthy mouth cleaning. And the 4355 is the scaling or the removal of gunk on teeth so that the doctor can do the exam. So I know in the past we used to use the 4355 as a kind of what we would call a catch-up prophy. And then we would bring them back in and either take them into replanting and scaling or take them into a healthy mouth prophy. So if this patient it could be a patient of record and they've had bleeding in the past, but you've done a healthy mouth cleaning on them, if they have bleeding and pseudopocketing, then the 4346 is the code to use, not the 1110.
Got it.
Does that make sense?
Next question. That makes sense. The next question, and I believe I'm interpreting this right, so it's a clarification. So the palliative code can be used when the doctor evaluates and provides treatment. That's the question.
Oh yeah, no. If the doctor evaluates, so let's say we use the exam code, the 120 or the 170, or the 140, limited evaluation, and they do not render treatment, so they don't adjust the bite, they don't do a filling, they don't do an extraction, but they
just provide
diagnosis and a prescription. Correct.
Got it. Perfect. Next question. What would be your recommendation for a fee for the 4346? And that great question. Here's what I'd suggest here. One of the services that we provide to all the Crown Council offices is the fee analysis for your area. So fees are, I did one of these just the other day in comparing a practice in Nashville, Tennessee and a practice that was in the Boston area. And the fees were so radically different that, you know, on a nationwide phone call to recommend a fee would be irresponsible. So
it sure
what I would
be.
suggest is if you have not had that fee analysis done in the last 12 months, then we're happy to do that for you. And the best way to do it is just to email us. You just email to director@crowncounsel.com. What zip codes, just put fee analysis in the subject line, and then the zip code or zip codes for which you'd like a fee analysis. And then we can run that and send it to you. And it'll give you code by code what the percentile fees are in your area based on the information that's available. So that would be the best way to answer that question.
Steve, a better email address would be success@crowncounsel.com.
There you go. Success.
And we also are, next week we'll also be sending out an email link so that you can just include it in a link and send it back to us, and we'll put them in the queue.
So on that same topic, I'm sure someone's thinking this, so I'm going to just go ahead and ask the question for somebody else. Can I do that? Which is, how do third parties pay for this new code, right? Is the 4346 going to be in the periodontal codes, or is it going to be in the healthy mouth prophy codes? Is there a deductible? Is there not a deductible? I'm sure everybody's reeling with those things. Earlier this week, I called Delta Dental. Now, that's only one of the players, so, there's 9,999 other dental insurance companies. So I'd highly recommend calling ahead if this is going to be a code that you use with the specific insurance company that patient is covered under, because I'm sure each carrier is going to treat it differently. But when I called Delta of Vermont, I can tell you that they classified this under the no deductible, and we're going to keep it in the same realm as the 1110. Now, that was just one company and one call. So I would highly recommend that if you have a patient with the presence of the need of gingival inflammation scaling, this 4346, I would call benefits office first.
Got it. Next question, Maribeth, is how often can you bill the 4346 in a year or a lifetime? How often can you use it?
I think that goes along with the question I just asked for myself, which is every carrier is going to cover this differently. Everybody's benefit package is different, and I would not be comfortable in giving you a two times a year or a 12 times a year availability. So I would again recommend that you call the patient's insurance company specifically and find out what their benefits are that they purchased.
Got it. Next one's a clarification on the 0180 code.
Okay.
So the question is, if a new patient comes in that says we charge the 0150, but how do we go about billing the 0180 if it doesn't cover the doctor exam?
Okay, so we would only use the 0150 or the 0180. We would not bill them both.
Right.
So the doctor's...
I guess the question is, does the 0180 include the exam or doesn't it?
Yes, it does. It's what it's saying is the dental exam is identical as far as the documentation that you would gather. So the doctor would do the diagnosis of the soft tissue, the hard tissue, because he's the only one that can really do the exam in the office, right? He or she. And if there is presence of periodontal disease or the lack of health or smokers, then we would use the 0180 code in place of, not in conjunction with, but in place of the 150.
Got it. Next question, can the 4346 be used before an 1110 like the old 4355?
The answer to that is yes.
Okay.
Now, are they going to, now wait, can I go back for 1 second, Steve? I want to make sure that they know that they can't bill both on the same day. So the 4346 would be a appointment, and then the next appointment could be 2 weeks away, could be 3 weeks away, whatever their standard of care is in their office for this. The next appointment would be a 1110. Or if there's still the presence of inflammation and bleeding and gingival infection, then it goes back and it gets to be a 43, 46 again.
Gotcha. Okay, and then that was the next question you've already answered. Can a 43, 46 and an 1110 be used at the same visit? The answer to that is no.
Correct. Individual appointments.
Yeah, next question, is the 43, 46 usually reimbursed lower than the old 43, 55? That's probably company by company, right?
That would be company by company. And remember, the 4355 is a once-in-a-lifetime code.
There you go. Then the next one, what is the what's the code for Caries view?
Oh, very good. The Caries view code is 0600. So D0600.
Gotcha. Okay, I think that is at least the questions for now. I'll reiterate what we talked about before. So there's a lot of information, obviously, and we will post a PDF file of these slides with all the codes at crowncouncil.org under the training tab under webinars, and that'll be posted here very shortly. So hopefully we can get the PDF file up here within the hour, and then the recording of the webinar will be posted here shortly as soon as we get it processed. So for those that want a copy of it, that is on its way, and you can access it through the website. Maribeth, thanks for your update today and your expertise. We appreciate it. It's a lot of detailed information. That's a lot of interest in that, obviously, to make sure everything is getting coded correctly. So thanks for all your help today, and thanks everybody for participating in our webinar. Look forward to seeing most of you at the annual event here in just a few weeks, and as well as on our next webinar. So have a great day. Thanks so much.